A very pleasant good afternoon to all, dear doctors. I am Dr. Rusni Mubarak from Himalaya Wellness Company's Scientific Services team. It is indeed immense pleasure to welcome each and every one of you, all our beloved and respected doctors who are already on board. One second, slides. Sorry for the interruption. One second, the slide is not changing. One second, doctors. Yes. So, as I said, it is indeed a moment of immense pleasure for me to welcome all our respected and beloved doctors on board. And on behalf of Himalaya Wellness Company, I extend my earnest regards and greetings to the eminent guest speaker and also all other doctors who are already logged in. Dear doctors, so virtually, let us all together light the lamp as a sign of keeping the flames of wellness and happiness alive. Thank you. And as you all know, wellness in every home and happiness in every heart has been our vision since 1930. And with your constant support and patronage, we have been, serving the humanity for the past 91 years. And for these past 91 years, we have been in constant connect with you through various means. And today, we have brought to you an online talk in connect to the contest World Kidney Day. So this year, the steering committee of World Kidney Day, they have declared 2022 as a year of kidney health to all. And the campaign is focusing on bridging the knowledge gap to better kidney care through kidney care education and also awareness in the public. But we know, doctors, World Kidney Day is not only a platform to raise awareness among the public, but also it is a reminder call for all health professionals to analyze and to update themselves on the latest aspects of disease of kidney. I'm sure you'll agree with me, among which urinary stones or renal calculi are the oldest and also one among the common afflictions of man, which still remains as one of the most, health burden in the public. And in the recent era, if you see in the current century, its incidence has increased not only in the industrialized countries but in the developing countries also. Even in India, urolithiasis is affecting almost 2 million people every year as per statistics, and almost the recurrence of urolithiasis is said to be 53%. So that brings relevance to our today's topic. The topic is complications during management of kidney stones. So before moving on to the, before calling upon the guest speaker, we have a surprise for you. That's nothing but an audience poll. Let's see. We have a couple of questions to you, dear doctors. Let us know what is your opinion. Angitji, over to you, please. Yes, here is the first poll question. As per you, what percentage of kidney stone patients end up with renal complications? A, less than 5%, B, 5 to 10%, C, greater than 10%, and D is greater than 20. You'll get 20 seconds to answer. You can see on the right side of your screen, you will be getting the options. Yes, Angitji, I think we should go for the result now.
1 second, sir.
Yes, please. Once again, a very hearty welcome for all those doctors who have just joined. We are amidst poll questions. Thank you, doctors, for staying online patiently. It's taking a while for getting the results to be displayed. Yes, here comes. So 57% of you have obtained a 5 to 10% as answer for the percentage of kidney stone patients end up with a renal calculation complication. Fine, 43% stand second. So let's see. We'll come to these answers because through today's presentation, today's online talk, we'll get a clear answer for this. Of course, these are variables as we know, but we will hear from the expert. Before that, we have 2 more questions. Angitji, please move on to the next question. Question number 2, poll question number 2, please. Yes, here we go. As per you, what size of kidney stones can be medically managed? Option A, only those with less than 15 mm size, then 5 to 10 mm size, or more than 12 mm size. D, all of the above. You will get 20 seconds. Place your poll your answers. You can see the option in the right side of your screen. Fine. Angitji, please. Thank you, doctors, for waiting patiently. Yes, here is the answer. 62% of the doctors, they say that 5 to 10 mm. Answer is B. It's the size of kidney stones that can be medically managed. Thank you for your response. And with that, we move on to the last question, last poll question. Angitji, please move on to the next question. Poll question number 3. Yes, what are the common complications you have come across while managing the kidney stone? Option A, infection. Option B, kidney injury. Option C, bleeding. And the last option D is all the above. Once again, you'll get 20 seconds, doctors. I hope you are enjoying this. And this is the last question in this poll section. I think it's time up. Pangitji, please move on to the answers very quickly. As you know, doctors, we are going to discuss on the topic complications of, complications during the management of kidney stones. Yes, here comes the answer. 48% of the doctors says it is infection. And just behind, we have 43% of them saying all the above as the answer. 17% of them say that it's kidney injury, and 9% of them say that bleeding. Fine, let's see. We need to dive deep into this. And thank you, Angitji. Kindly let me share my screen. Fine. So, doctors, as I said, we need to dive deep into this context. And today we have a veteran and expert speaker with us to discuss on the topic. And please join me in welcoming. 1 second, there is a delay in getting the screen share and screen changed. 1 second. Fine. Sorry for the interruption. Once again.
Bhagwan.
ఇన్ఫార్మ్ చెయ్యు. నేను ఇంకోటి మీకు సపరేట్‌గా జస్ట్
Yes, doctors. Please join me in welcoming Dr. Nagarajaya sir, the head of Sushruta Urology and Andrology Clinic, Bengaluru. He is with us today. And as you know, Dr. Nagarajaya is a senior urologist and andrologist with having a 25 years of experience. And he has a credit of removing the largest kidney stone weighing more than 450 grams. And he has received Dada Sahib Phalke Award in 2021 for his contributions to urology and also his service to the patients. He has performed more than 30,000 surgeries, including the removal of renal calculi in more than 5,000 patients. He's an expert at laparoscopic surgeries, including nephrectomy, pyeloplasty, retrocaval ureter, adrenal surgeries, and radical surgeries. He is much experienced in handling most complex uro-oncological surgeries. He is a master at radical cystectomies and construction of neobladder. And he has been a part of many national and international symposia, workshops, and conferences. And his innovations and ideas are very well incorporated in the day-to-day urological practice. And he was the counselor, member, treasurer, and even president of Bangalore Urological Society, and also is a member of Urological Society, India, Karnataka, and also Kerala. Sir, it's my honor and privilege to call you upon to take over the session. Over to you, sir. Thank you.
Thank you. Thanks for your nice introduction. Hello, good afternoon, doctors.
Yes.
Hello, good afternoon to all of you. The doctors who have taken time to just go through the what is the urolithiasis on this World Kidney Day. I welcome you all. We'll go in step by step regarding the definition, incidence, epidemiology, etiology, what is the presentation, then how do we diagnose, what are the types of stones, and how do we manage that, medical as well as surgical. The definition is nothing but formation of a solid calcareous stones made up of several crystals. We call it as crystals. They aggregate and they form stones in the anywhere in the urinary tract. They are called urolithiasis. Once we come to the incidence, particularly in Western countries, 1 to 5% of the population, they will have incidence of the stones in their lifetime. And of course, in developing countries, it increases because of the increased dietary proteins as well as cereals and pulses. And in our India, it's very common in northern India as well as northwestern India because of tropical climates. Once the whole globally, it's around 10% in the general population. And the estimated lifetime risk for any one person developing stone is around 12% in Caucasians, and it is 2 to 3 times more common in males than in females. The reasons I will tell you later. Then, of course, it occurs more in adults than in elderly persons because of their increased activity, and it's more often in elderly person compared to children. The reasons I will let you know later in the talk. Most patients fall into the middle age group because they are the ones who are working and they're more active. They don't take proper diet, they don't take proper fluid. That's the reason middle-aged persons are the most commonly affected. And with women, kidney stones occur more commonly among the post-menopausal women. That's due to absence of estrogen, which causes stasis of urine and infections that leads to stone formation. Once a patient passes a calcium stone, the likely likelihood of developing a second stone is approximately at 1 year 15%. It increases to 35 to 40% by 5 years and 50% by 10 years. And within next 20 years, there are chances 70% can have another stone. How the stone forms? The sequence of pain, I think all of you should be aware of that. It's nothing but a mixture of solids and liquids. See, we call it supersaturation. Whenever urine, water content of the urine is saturated with the minerals, it's normally goes as solvent in the urine. Once it was supersaturation, it forms started solids. That leads to nucleation. Then that forms clusters. Then the crystals will form. Crystals will aggregate. That leads to retention, and then stone formation. Stepwise forms. It is all due to supersaturation of urine. That means imbalance of the liquid content as well as salts and minerals. The most commonest cause for urologists is the decreased urine volume. That means decreased water intake or decreased in the water content in the body due to so many reasons, which I will let you know. As I said, it's habit of decreased fluid intake. As I said, the working people, middle-aged people, everybody will be tension. They will be worried about their work, their earning. They don't drink a lot of proper fluids. They keep running around for their work or their anything, and they don't have facility somewhere. As I've seen so many places, they don't have facility to pass urine. That's why they don't drink water, thinking that will get infection. So that causes increased incidence of stone. And of course, climate. Like in summer, the stone increases in incidence during summer months. As persons normally they sweat a lot, they don't take enough water. And sometimes there will be intestinal fluid loss, maybe like frequent lose, like IBS, irritable bowel syndrome we call. They lose a lot of fluid in the motions. Such patients also will develop urolithiasis. There are some inhibitors in the urine, presence of inhibitors which decreases the chances of stone formation, which include pyrophosphates, glycosaminoglycans, pentasans, nephrocalcin, etc. If these stone inhibitors are reduced in the urine, the chances of stone formation are more. The another few stone inhibitors are tam-asphalt protein, RNA fragments, and acid polypeptide, which practically we don't test it and we don't do that. The important thing, once the fluid, we take care of fluid intake, the next comes the dietary factors. As we see, pure-rich food like are responsible for uric acid stones, and any excess of vitamin C, vitamin D also can cause increased calcium absorption and stone formation. Then vitamin A deficiency. Vitamin A deficiency causes desquamation of epithelial cells. That means epithelial cells will be shed in the anywhere in the tracts like intestinal tract, urinary tract. So that causes nucleation and that leads to the stone formation. And of course, any increase in calcium intake or decrease in phosphate intake or any increase in oxalate intakes, which I will let you know what are the foods which are rich in calcium and oxalates, that causes increased incidence of stones. Then other factors, prolonged incumbency. So whenever, for some reason, particularly in orthopedic surgeries or orthopedic traumas, spinal trauma, arthritis, prolonged incumbency, when patient is taking bed rest, there will not be any mobility, that leads to decalcification of the bones, and that increases calcium levels in the blood and its excretion in the urine, that leads to aggregation of the crystals and development of the calcium oxalate stones. Then of course, alcohol. Alcohol can increase the crystallization of the stones inside the kidney. Many patients ask me, doctor, if I take beer, the stones will go out. I tell them, whatever the stone which has come to the end of the ureter, it might go out, but again inside the kidney, they form crystallization and increases the chances of stone formation as it increases crystallization inside the kidney. So avoid alcohol. Then there are some endocrine factors like hormones. Hyperthyroidism particularly is very important. It causes increased calcium levels in the blood, that secretes more calcium into the urine. It leads to increased calcium excretion and stone. So whenever patient is having multiple stones or recurrent stones frequently, we have to rule out parathyroid levels. It's in the blood. Next comes reaction of the urine, particularly like the pH of the urine, whether it's alkali or alkaline. If it is acidic urine, the chances of uric acid stones are more. If it is alkali urine, chances of calcium storage stones are more. That's why we have to maintain balance of the pH. Then other factor is for nidus. We call it nidus. Over that, the calcium oxalate stones will form. That's infection, presence of infection, or sometimes bacteria. They form a nidus, and that leads to stone formation. Then, of course, lack of calcium solvents. The chief calcium solvents are colloids, that's mucin chondroitin. In a decrease in that, it causes increase in the calcium stone formation. Presence of citrates, as I said, the why females are less, stones are less common in females because female urine, for some reason, they contain more of citrates. Citrates inhibit stone formation. That's why females are less likely to form stones compared to the males. And there are some organic acids, amino acids, which forms a increase in calcium in stone formation. Infection, as I said, sometimes bacteria, particularly dead bacteria, they form nidus for the stone formation. And there are some urea splitting bacteria, Proteus, Klebsiella, all those things, they increases the nucleation of the calcium and increases stone formation. So then the other factor I was telling in etiology, the old males, they develop more of kidney stones because they will develop obstruction secondary to prostate, benign prostatic hyperplasia, CF prostate, stricture. Whenever there is obstruction to the urinary tract, there will be stasis of the urine, and that leads to stone formation. Other common factors what we routinely see is following surgery, like any presence of foreign bodies inside the urinary tract. Like we place double J stents once we remove the kidney stones or aortic stones, which many patients they neglect or they will not come to take it out. Over that the stone forms. And another thing what I've seen is this copper T. I've seen our hernia mesh. They migrate into the bladder and over that the stones form. These are other foreign bodies. Any foreign bodies are sometimes non-absorbable sutures we use for repairing the urinary tract. Sometimes they can also form nidus for the stone formation. So then, as I said, why children? The children usually normally less incidence compared to the adults. It was old thought now, but nowadays we are seeing more of children also having the stones because their food habits are being changed. They eat a lot of this fast food, oxalate contain chocolates, ice creams, Pepsi, Cola, all those things, they contain a lot of oxalates, which increases incidence of kidney stones or urolithiasis in them. Coming to the clinical way, how the patient presents with. The commonest symptom is pain, even though many times stones are silent. Pain only happens whenever there is movement of the stone from one part of the urinary tract to other, particular ureter, or it's a quite big stone which causes tension on the kidney or it distends the kidney, then only the pain will come. Otherwise, many of the renal stones are if the stone stays at one place, it doesn't cause any pain until late stages. So the fixed renal pain is the one symptom where, particularly with the oxalate big stones, because the calcium oxalate stones they contain spikes, it irritates the urinary tract, that causes pain. Whereas phosphate stones normally they are smooth, they don't cause symptoms until they become very large and occupies almost all of the kidney. Then what is typical renal colic? Whenever stone attempts to pass from the kidney to the ureter across PUJ, that causes typical ureteric colic. The pain we say it is radiates from loin to groin. It's called loin to groin, from the lumbar region to the iliac region and to the testes and to the inner side of the thigh. It's a typical of renal colic. We don't require any diagnosis in such cases. That is severe. It's the most severe pain after delivery, normal delivery. Renal colic, ureteric colic is considered the second most severe pain after the normal delivery pain. Then the referred pain. Sometimes pain can refer, as I said, along the lower abdomen, along the thigh, or along the testes, or in sometimes opposite kidney due to reflex mechanism. In case of bladder stones, pain is felt over the suprapubic region or hypogastrium, or it can be referred to the tip of the urethra, that's penis or labia major in females. The next thing is hematuria. Hematuria happens whenever the stone moves, it causes abrasions that leads to hematuria. Hematuria can be terminal in case of bladder stones, or it can be initial in case of ureteric stones, or it's uniform, that's throughout the urine mixed with blood in case of ureteric or renal stones. Then the patient also can have burning micturition. Burning micturition can be due to associated with infection or due to abrasions caused by the stone. Patient can have vomiting. Whenever the ureteric stone obstructs the kidney, the patient can have reflex vomiting. And that can lead to dehydration and all those things. Then the patient can have sometimes fever. Whenever he neglects the stone, he will develop infection, silent stones. The infection will happen and you develop urinary infection leading to fever. So these are the common symptoms. Of course, other symptoms being whenever patient neglects case, patient goes in for kidney failure, such as the patient can have like acute renal pain. Whenever bilateral both the ureters are blocked, patient will go in for acute kidney failure, leading to pain, vomiting, dehydration, all those things. And if patient goes in for chronic renal failure, he can have edema, swelling of the body, inability to eat, cachexia, all those things can develop. These are all late stages once complications develop. Then an examination, as I said, typical ureteric colic can be diagnosed by anybody, loin to groin radiation. Then an examination, you can have pain, tenderness in the lumbar regions or renal lung. Renal lung is costovertebral lung, behind the back, below the ribs. So on either side of the vertebral column, the tendon, that is typical of any renal pathology. If tenderness is there, normally either it is due to stone or infection, pyelonephritis. Then in case of ureter, it varies according to size of the site of the stone, and sometimes, as I said, there can be obstruction or sepsis. It can obstruct the urethra. Any stone coming out from the bladder to the urethra, it can block the ureter, and patient can present with retention of urine. These are the few commonest symptoms. How do we diagnose? The basic thing, as I said, the history is very important. Then the simple urine examination. In the urine, we can find presence of RBCs. If there is no infection, RBCs will indicate it's a stone. There should be more than WBC. If WBCs are more, then normally we suspect along with infection. Then any culture, if we suspect infection, you can do culture and sensitivity. Then in blood, we see normally any affected in renal function tests, kidney function tests, increase in creatinine or urea, that indicates dehydration again, secondary to patients vomiting and all. So then the next commonest investigation is almost we consider it as a part of clinical examination, ultrasound examination. It's simple, it has no radiation, it can be repeated at any times. Of course, it's personal variations. It depends on the person doing that. A lot of variations will be there in identifying the stones. So even though it may not give 100% the identification of the stone, it can give one size of the stone, site of the stone, its effects on the urinary tract, all those things can be made out by simple ultrasound. Suppose whenever we do ultrasound, sometimes we may not be able to see the size of the stone, particularly in the mid and lower ureters, we may not be able to. In such case, we go on for QUB X-ray. Any radio, almost 90% of stones are radio dense. So such case we can see an X-ray, and still we suspect we can do plain CT scan, simple plain CT scan. You can see the size and site of the stone. Intravenous urography is indicated only when we suspect anatomical abnormalities in the urinary tract. That means when you suspect stones are secondary to anatomical abnormality, like PUJ, congenital PUJ obstruction or any urethral obstruction, such cases, IVP or contrast CT scan will do. Of course, still we do not know what is happening, then sometimes we do cystoscopy and ureteroscopy to diagnose the stone itself. Then of course, whenever we suspect multiple or recurrent stones, we do metabolic evaluation. In that metabolic evaluation, we see parathermone, serum calcium, uric acid and phosphate levels, as well as urinary calcium, citrate and phosphate levels. So basic things are urine routine, ultrasound and kidney function. These three are basic tests. All other tests can be done by the specialist. Then what are the types of stones? As I said, common types are calcium oxalate stones, followed by phosphate stones and uric acid stones. Then cystine stones are and xanthine stones are very rare. As you can see here, the calcium oxide consists of almost about 80% of the stones, followed by phosphate, which are around 10%, and uric acid around 5 to 10%. Stoveite stones normally they occur in presence of infection. They form the Stargardt calculi. These are all same thing. Once we diagnose, then how do we manage that? There are medical management as well as surgical. Medical management, of course, it depends on the site of the stone, size of the stone, and its effects on the urinary tract as well as body. That means complications. Whatever may be the etiology, every patient should be considered to avoid Yeah, that means drink lot of water. That is common to all the stone patients except in case of kidney failure. Patient presents with kidney failure, then of course he should not take water until he is evaluated and treated accordingly. The how much water patient should take? It is a common question all the patients ask. See, suppose in a like summer like this, he needs to take around 2.5 to 3 liters of water. In winter 1.5 to 2 liters. Normally, I say you see to that your urine should never be yellow. If urine is yellow, then it is insufficient water intake. The medical mind depends on the, again as I said, depending on the cause of the stone. In case of hypercalciuria, this idiopathic, we don't know why the stones are forming. Then we give them diuretics. Then uric acid, then we give uric acid antagonists like allopurinol or febuxostat. And if it is a hypocytruria, secondary to hypocytruria, we give alkali, magnesium citrate alkalis. As you can see here, in uric acid stones, alkali plus allopurinol. Nowadays, we instead of allopurinol, we give febuxostat. Then stoic stones, it's an infective stones. We have to supplement with antibiotics. And in cystine stones, massive fluid intake. Cystine stones are very rare. Then coming to specific treatment of the stone. How do we manage ureteric colic? That's pain, severe pain associated with stone. Normally, everybody give diclofenac or some NSAID antibiotic. Ideally, NSAID should not be given because NSAID they inhibit renal blood flow. As it is secondary to colic, renal blood flow will come down, secondary to pressure effects. So if you give again NSAIDs, patient can have renal shutdown of that particular kidney. Even though obvious renal failure is not there because other kidney is functioning normally, this particular kidney will shut down. That's why it's better to avoid NSAIDs. We can give opiate derivatives like tramadol or Fortwin, all those things you can give, or smooth muscle relaxants you can give, like rotavirin, buscopan, or calcium channel blockers we can give. Then specific treatment depends on location of the stone, its extent of obstruction, and the function of the affected as well as unaffected kidney. Because if it's single affected kidney, then we have to manage it judiciously. If it's other kidneys functioning properly, that again influences the treatment. Then how the stone is progressing over the medical management treatment. See, we say medically you can manage, particularly when there is obstruction. Up to 4 weeks, no definitive damage to the nephrons will happen if stone is staying at one place. If stone, migrating stone, probably you can wait still longer. Otherwise, non-migrating stone causing obstruction, within 4 weeks it has to be treated. Otherwise, nephron loss will happen. That's what we say. So it all depends on the progress of the stone. Of course, we have to follow it up with ultrasound, frequent ultrasounds. And the other thing, we have to also assess risks of any anesthesia or surgery involved. Of course, severe obstruction, infection, intractable pain, and serious bleeding are definite indications for removal of the stone. Even the stone is very small, say 5 mm, 6 mm, sometimes patient will not tolerate pain. In such cases, we have to go in for emergency removal of the stone. See, how do we decide which stone requires which treatment? See, normally less than 5 mm, we say it would go with medical management with few exceptions. So just drinking of water, sometimes we may give IV fluids, but even though it doesn't have any role because even give IV fluids and Lasix, that is diuretics, the opposite kidney, normal kidney will secrete, the affected kidney will not secrete during acute colic. So just intake of water and we give some medicines, as I said, smooth muscle blockers, painkillers, that's all we require, and antispasmodics. And so particularly if it gets stuck at the lower ureter, then we give alpha blockers. Alpha blockers, tamsulosin, alpha-leucin, silodosin, those things we give. And if it is more than 5 mm, the chances of spontaneous passage of stone comes down, say by 8 to 10 mm, almost it becomes 10 to 20%. So as the size increases, chances of, provided there are no complications and patient is tolerating pain without any like pain, fever, and vomiting. These 3 symptoms are very important. It shows that there is more pressure effect on the kidney. So these symptoms are not there, we can wait for 4 weeks. If it is say around 8 to 10 mm, less than that. More than 10 mm, usually we don't wait, straight away we'll advise. And even patient should wait without taking any analgesics. So you not taking analgesics for 2 to 4 weeks, it again he will lose his nephrons, kidney. Because surgery and lithotripsy, it again it's not a uniform treatment. As I said, it depends on size, site, as well as its effects. See, these are medical man. Currently, we collect medical tamsulosin 1, as I said. Nowadays, silodosin is also there, and calcium channel blockers. Normally, they are used for antihypertensives. So we are also use this in lower uteric stones. Normally, they will help. And for bigger stones, the available treatments. I don't know whether it becomes too much if I keep on explaining each and every stone. Generally speaking, we say the ureteric stone, if it is less than 15 mm, we from below we pass ureteroscope, powder the stone either using laser or pneumatic lithotripter and remove the stone. If it is more than 15 mm, sometimes we do RS, we call retrograde intrarenal surgery. That's flexible laser we use. That can be used. If it's more than 2 centimeters, we have to do laparoscopic or open. In case of kidney stones, again, say if it's extra ESW, it's the most simple and cheap treatment available for larger stones. If it is a more than 15, less than 15 mm stone inside the kidney, we give this treatment. It's called extracorporeal sacroilithotropsy. Where patient, I said, done as a daycare procedure without any anesthesia, just some analysis and all, you can give that. Of course, you should not have any infection associated with, you should not have any coagulopathies. That means his coagulation parameter should be normal and there should not be any obstruction and there should not be any renal failure. Such cases, ESW will not work because even though we powder the stone fragments has to come out in the urine. So if there is any obstruction to the urine flow or there is no secretion, it will not help. Then if it is particularly bigger, more than say 15 to 20 mm, we say PCNL. PCNL can be done up to 5 centimeter stones, where you make a puncture in the renal angle, you dilate the tract, you pass the nephroscope through that, you just fragment the stone and remove. And even if sometimes whole kidney is occupied, like so all the calyces and fully staghorn calyces, such cases we might have to open and remove the stone. The recent one RIRS, it's called retrograde intrarenal surgery. From the urethra itself, we pass the flexible uteroscope. Earlier, only rigid uteroscope was there. Nowadays, this flexible uteroscope is available. Through that, anywhere in the urinary tract, we can remove all the stones, say less than 15 to 20 mm, including urethra, bladder, then ureter, kidney, anywhere you can do. But normally, it's used for intrarenal stones. For ureteric stones, we usually use rigid uteroscope. Then what about bladder? In bladder, as I said, so anything cystolitholopixical, through cystoscope we fragment the stone and remove. If it's very big, in like PCL, we do PCCL, make a puncture in the suprapubically and just fragment the stone and remove. If it's very big, which I removed, say even 10 centimeter, 15 centimeter stones, we have to open and remove. Then urethral stones with acute retention, if possible, do cystoscopy, fragment the stone, remove the stone, put it the catheter. These are the invasive procedures. Then that's about management. Then coming to diet, normally all the patients will ask, doctor, what should I eat? What should I not eat? So generally, I say avoid eating fast food. That is a Western food which contains a lot of oxalates and calcium, like cheese, burger, pizza, this Pepsi Cola, irritating. They contain a lot of oxalates. Then alcohol, non-vegetarian, red meat particularly. Those things I ask them to avoid. Among vegetarians, say nuts, beans, cheese, and these things should be avoided. These are the foodstuffs with high calcium, like milk, curds or yogurt, cream, cheese. All those things should be cut down. Spinach, tea, coffee. That I forgot to tell. Tea, coffee contains oxalates. So if patient is taking a lot of, it's very common, even in the non-vegetarians, everybody, I ask them to avoid maybe 1 or 2 cups a day is allowed, otherwise let him cut down. Then what are the complications? The complications usually happens in neglected cases, as I said, or in silent cases. So one is, as I said, commonest is infectious sepsis. Infectious sepsis normally they will come early because patient will have fever and pain. We treat accordingly whether it's pyelonephritis or it is a urinary infection. We treat accordingly and then you remove the stone according to size of the stone. Then sometimes because of obstruction there will be extraction of urine and that leads to infection as well as perinephric abscess. That accordingly we treat. Then the last one is the renal failure. Either it's acute or chronic. If it's acute renal failure due to either ureteric obstruction or bilateral ureteric obstruction or urethral obstruction. If it is urethral obstruction, just placing a catheter will relieve. If it is bilateral ureteric obstruction, normally we place double J stents. So as an emergency, once patient recovers, then we can manage the stones. Thank you.
Yes. Thank you so much, sir. It was indeed a feast of knowledge, I'm sure, because right from the beginning to the end, inch by inch, you have explained everything. And dear doctors, I believe you all have a wonderful session, a very nice, informative session. 1 second, let me share my screen by the time. Yeah. Yes. So I'm sure, thank you so much, sir, once again, for a very elaborate and covering every aspect. Thank you so much. I'm sure, doctors, you are waiting with your queries. Please feel free to share your queries or chat, into the chat box. Please key in your queries in the chat box. And by the time you share your queries, I'm taking a few minutes. Sir, we have discussed on the complications also. Apart from the complications, what we have discussed, definitely, I'm sure we all agree that recurrence is also one of the important challenge which every one of us are facing in the management of urolithiasis. So here I would like to make a note on the scope of plant-based medicines, because plant-based medicines are not only in the prevention of recurrence, but also in dissolving the renal calculi. A lot of studies has been conducted that has been well studied and well documented in the recent years. So along with the conventional modalities, plant-based medicines which are scientifically tested and also clinically proven are nowadays being considered effective and safe in the management of urolithiasis. You know very well, doctors, Himalaya wellness companies Cystone and Cystone Fort are always leading ahead of its competitors. 1 second, I'm struggling with these slides. It's not getting changed. Let me reshare it once again. Sorry for the interruption, doctors. Some technical glitches are there. Still.
Hello.
कितना हुआ?
Answer.
It seems Dr. Mubarak must have lost his connection. Sir, I would like your attention here. One of the queries here is role of IV fluids in stone formers.
I should say there is no role unless patient is dehydrated or patient is vomiting and he can't eat. Then only IV fluids, otherwise there is no role.
Another doctor has asked, does VUJ stones with ureteric dilatation cause kidney damage? Or if so, the back pressure effect to cause kidney malfunction, how much time does it take?
Yes, as I said, non-moving stone with hydroator nephrosis after 4 weeks, it causes microscopic nephron damage. So how long it will take cause fully kidney failure? There are no records available. So more than 4 weeks, non-mobile stone with hydroator nephrosis can cause microscopic nephron damage. Of course, with time passing, keeps on damaging the nephrons.
Thank you, sir. Is there a component? Is there a component of luck keystones causing functional damage to kidneys?
There's no fluke or luck actually. Sometimes we get reflex damage, and sometimes we don't know what it is. So sometimes deflect damage can happen. There's no luck or fluke in that.
One more question, sir. I don't know, like it seems to be a little question. Can allopathic doctors prescribe Ayurvedic medicine? Is there any government guidelines or law that?
No, actually, reverse guidelines are there. Ayurvedic doctors can practice allopathy, but reverse, nobody is talking about that. But practically, people keep using that. And of course, as I have seen, I'm a consultant in many hospitals. Duty doctors, resident doctors are all, many Ayurvedic doctors are there, and they keep prescribing this one. So maybe some crosspathy can happen. There are no guidelines available.
Thank you, sir. Actually, allopathic doctors, as you said, can prescribe because if medicaments are
Effective.
given evidence-based medicine, then of course for the benefit of patients, just as Dr. Mubarak was highlighting about recurrence. In recurrence, I think you also must have seen good results with that Cystone 4. What is the treatment for pedal edema?
Now it is yes, there is no cause, no renal. Of course, we have to rule out causes like renal, liver, cardiac, and hypoproteinemia. If they're not there, sometimes, particularly in a hypertension patient, they will have dependent edema. Whenever they will prolong journey and all, there's no treatment unless they should keep their feet at a height. Other than that, there's nothing. Unless there is no cause, there's nothing. It's only dependent edema.
So another doctor has asked how to manage a stone patient with erythrocyte and 8 mm lower pole renal stone. How many days stent can be extended?
The erythrocyte has to be incised because it will be causing obstruction of the urine flow. When we do cystoscopy, we incise the erythrocyte, so that will relieve that. 8 mm lower pole renal stone, normally we do either lithotripsy, that is ESWL, or RIRS. Stent can be there up to maximum of 3 months, normal stent. Nowadays, silicone stents are available, they can be there up to 1 year, which we keep normally in CS cervix patients or any secondary tumor, retroperitoneal tumor, ureteric obstruction. We keep silicone stents for about a year or so.
Thank you, sir. Another question goes like this. How early can we find out that the person is developing stone before a scanning or pain starts? Some random tests are common signs or symptoms.
And no, only test maybe one is urine. In urine analysis, we can see some crystals, stone crystals. That's one reason. Nothing scan. Other than that, there's nothing.
So any new methods in treatment of urinary calcium?
No, there's no new methods. No, other than RARs, that's the latest. That's the lasers. That's the latest.
In the comments, some clinics give IV fluids fast and give IV antispasmodic and diuretic IV.
During acute colic, it's not justified because during acute colic, that particular kidney will not be secreting any urine. Whatever you give IV fluids or LAS, it's only opposite kidney will be secreting, so it's not useful. Maybe whenever there is a patient recovers from acute colic, sometimes if patient is not able to take water, then we may rush in some fluids along with diuretics. it might help to some extent.
One more question is how diabetes mellitus can impact on
The both put together, say, diabetes causes kidney damage, put together uncontrolled, then controlled diabetes over a time, it keeps causing kidney damage, like vascular damage, along with deposits and all. So vascularity to the kidney will come down and causes microscopic damage. Whenever stones are added upon that, then definitely the damage will increase.
some questions are being repeated, sir. One more question, what one of my friends had asked me was PUG obstruction. There is no calculi. Pyeloplasty is also being done.
Yes.
Is there any chance of recurrence of this obstruction?
Yes, there is chance. There is chance. It's a scar. So following surgery, if some patient can develop scar, there are chance, say about 5 to 10% recurrence.
Oh, there once again surgery is the only answer, sir.
Yes.
Are there any other questions? Meanwhile, let me check whether Dr. Mubarak has joined.
Yes, sir. I mean, sir, I
thought maybe internet has given you.
Yeah, some issues are there, unfortunately. Thank you so much for pitching in, sir.
Medical and technology usually do not go hand in hand.
What to do, sir? Anyways, I owe an apology to our beloved doctors who are on board and also to our respected guest speakers, sir. Sorry for the interruption happened. And thank you so much, Srikanth, sir, for pitching in. I think we had a good number of questions already. So before we move on to the concluding remarks and also the take-home message from our respected guest speaker, I'm taking a couple of minutes because I was just saying about plant-based medicine. So once again, I'm trying to share my screen. Yes, sir. I hope it's visible now, isn't it? Srikanth, sir.
Yes, doctor, it is visible.
Yes. So I was saying, as far as the plant-based medicines are concerned, especially scientific tested and clinically proven medicines are concerned, Himalaya wellness companies, Cystone and Cystone Food, these two brands are far ahead of the competitors of its kind with respect to its quality, efficacy, and also safety. So, doctors, I won't take much of your time, just 5-6 minutes, not more than that, because you very well know about our brands already. A quick glance, a glimpse, I should say, a glimpse of Cystone and Cystone Food. So it was in 1943 we launched Cystone tablets, a power brand to expel kidney stones and prevent the recurrence, which is now available in more than 75 countries, the market leader in urolithiasis segment, and the only brand in the segment with meta-analysis study. And in 2008, as you know, we came with a Cystone syrup as a natural choice in UTI. And of course, it has proven results in preventing the recurrent UTI, which, as Sir said, which has been considered as one among the etiological factors of urolithiasis. Still, our quest to provide effective solution continued, and finally, we presented before you Cystone Food for managing larger stones in the sense stones above 7 mm and even up to 12 mm. Doctors. So, Cystone and Cystone Food, both they are powered with herbal ingredients with pharmacological activities. Typically, I should highlight, or I'll highlight 4 pharmacological action. Number 1, ingredients with anti-lithiatic action, then lithotriptic action, anti-inflammatory, and diuretic action. So, as far as anti-lithiatic action is concerned, Cystone Food contains ingredients like Didomocarpus pedicellata with key constituents like didymocarpol and didymocarpinol, which inhibits the calculogenesis. It prevents the deposition, accumulation, and supersaturation of the calculogenic substances in the urine. On the other hand, we have ingredients like Mangishta, that is Rubia cordifolia, which has been proven, the hydroalcoholic extract of Rubia cordifolia has been proven to bring down the levels of calcium, oxalate, and phosphate levels in the urine. And ingredients like Rubia cordifolia has proven to bring down the oxalate levels. It is said that it has the capability to inhibit the glycolate oxidase enzyme, which oxidizes the glycolate into glyoxylate, which is further converted into oxalate, as we all know. So it helps in dissolving the oxalate stones also, doctors. Moving on to the next pharmacological action, that is lithotriptic action. We know we have Saxifraga ligulata as one of the key ingredients, which is usually seen in the hilly areas. It is grown in high altitudes, which grows within the slits of rocks. and have inhibitory effect on calculogenesis, and also it inhibits crystal aggregation by dissolving the glycoprotein mucin, which binds the stone promoters or the particles, And definitely, I'm sure you'll agree with me, the action, anti-inflammatory ingredients, ingredients with anti-inflammatory action and diuretic action has much relevance in the management of urolithiasis. So we do have ingredients like Cyprus caryopsis and also Osmium basilicum, which are potent anti-inflammatory agents, and ingredients like Acaranthus aspera and also Tribulus terrestris with diuretic action. So Tribulus terrestris is known, it's well studied, and it's known to increase the GFR, glomerular filtration rate also, doctors. You know very well, Himalaya Wellness Company, we always validate the formulations which we find with modern research. So Cystone has also underwent a lot of studies, almost nearly 90 papers have been published so far, out of which 79 are clinical papers and 9 experimental papers are there. And so in the interest of time, we are not going to those studies, but however, I would like to highlight 2-3 studies, very simple in 1 or 2 slides, that's all. This is one of the study being conducted by Dr. Jayaraman, who is a consultant urologist at Balaji Medical College from Chennai. And this open clinical study, it involved 65 patients of either sex between an age of 18 to 50 years. And they were having a stone measuring greater than 5 mm and also less than 12 mm. And they were administered with a Cystone port at a dosage of 2 tablets BID for 3 months. And doctors, I would like to say that this study was published in Journal of Urology and Research also in November 2017. So it was really, the result was really promising. You can see it's quite evident from the graph itself. Out of the 65, 36 of them had complete expulsion of stones. And if you analyze the rest of the stones, if we look into the mean calculi size before treatment and after treatment, it is very clear from, you can see here, it has been brought down from 6.82 to 2.91 mm doctors. And if we analyze, the complete expression of stones with respect to the size of the stones, 53.3% of the 100% expelled stones belong to the size category 7 to 12 mm, while 57.1% belong to the size category 5 to 6.9 mm doctors. This clearly highlights the efficacy of Cystone port, and Cystone port has clear reflections on the clinical parameters also, as we can see here on the screen, like polyp pain, abdominal pain, dysuria, etc. I'm not reading out everything here. And I would like to highlight one more thing, not only in this under medical management, under surgical management also, Cystone port can be an aid. Here you can see a study. It is an independent investigator initiated study on Cystone. This is, conducted under, Medical University of Moscow, and the study was published in Russian Medical Journal. Here, a combined therapy was given, that is ESWL plus Cystone. The overall subjects involved in this study was 280. It was a controlled clinical study. Of the 280, 212, they got Cystone therapy along with ESWL. What we found is, the conclusion is, Cystone plus ESWL accelerated the discharge of fragments and disintegrated stones. We know the residual fragments, the difficulty in getting it out, and also the reduced the occlusive complications like hematuria, pain, and even pyelonephritis in Cystone receptors. So that clearly highlights the utility of a brand like Cystone port in surgical management. Even we can use it as a combined therapy. And as a preclinical application, pre-surgical application also, Cystone port plays an important role. Here you can see the study was again published in Kazakhstan Medical Magazine. It was a controlled study involving 65 subjects. 31 underwent only lithotripsy, while 34 of the subjects, they had a Cystone therapy prior to the lithotripsy section. So for almost 1 month, the stone size reduced to from 7.3 to 6.2 mm. And it was quite interesting to note that only 45% required more than 2 lithotripsy sessions in Cystone treated group, as compared to 70% in control group doctors. So that clearly highlights once again the efficacy and safety of Cystone. Cystone and Cystone port together. And I would like to conclude saying that Cystone port can very boldly be indicated for urolithiasis, that is urinary stones up to 12 mm. That is in larger stones, Cystone port. And of course in crystaluria in adults, and of course in children about 12 years, and also in post-lithotripsy urolithiasis in a recommended dosage of 2 tablets twice daily, doctors. So that's all about brand Cystone and Cystone 4. And with that, we move on to the concluding remarks and take-home message from our respected guest speaker, Nagaraj sir. Sir, over to you, sir, please.
Dr. Mubarak, there are a couple of questions.
Yes.
Sir, can we take two more questions? Last two more questions, sir.
Sure, sir. Sure.
Sir, there is a question about what are the absolute indications for surgery? Sir, mute.
Absolute indications for surgery are complications. As I said, any complications are absolute indications for surgery.
Thank you, sir. And Dr. Anand.
Thank you, sir. And Dr. Anand Shirolkar from Bangalore, he asks, in cases of renal stones of 28 millimeter, what treatment, and in case what if it is repeated?
28 millimeter stone, we do PCNL, percutaneous nephrolithotomy. That is the treatment. If it is repeated again, holds good size and size of the stone.
Maybe I think if I can pitch in, Dr. Anand, you should suggest something to prevent. I think you have just now heard. Dr. Mubarak?
Yes, sir.
Yeah.
Yes, sir. Before moving to the concluding note, I'm really glad to share that more than 750 doctors have attended today's program. And we are really happy, sir, and much, big thanks, emphatic thanks to Nagaraj sir also, Dr. Nagaraj sir also. And thank you so much. Will be still the official vote of thanks is pending, so I cannot completely say and finish off the thanks. Anyway, sir, we would like to listen to you a final take-home message, a concluding remarks from your end in a very crisp way. Kindly, sir, over to you, sir.
Yeah, but take-home message is
Mute time.
Srikanth sir, please mute.
Yeah, see, summer is starting. Ask your patient to drink a lot of water and ask them not to neglect water taking because of their busy schedule of work or whatever it may be. And second thing is ask your patients, see, whether we treat allopathy, Ayurveda, whatever it may be, or just simply drinking water. There is some time limit for the stones to go out. Normally, patients, what they do, they don't come back for follow-up saying that he had no pain, fever, nothing, or burning. After complicated, they'll come back. So ask them whether pain is there or not. They have to follow it up ultrasounds. So if it's etiology is there, after 1 month, he has to repeat the investigations. If it is no etiology, after 3 months, it has to be repeated. Whether the patient has symptoms or not, that's very important. So if the same routine is followed, complication will never happen in kidney stones. So, thank you.
Yes, sir. Thank you so much, sir.
Thank you so
And
much,
thank
sir.
you, doctor. Yeah, thank you, doctor.
Just to add, sir, there are 150 audience who are currently watching on the YouTube this webinar. Thank you so much, sir.
Good to know, Praveenji. So thank you, sir, and thank you, doctors, for your queries also. Now, I invite our sales manager, Dr. Girish G. Nandikadu, to deliver the vote of thanks. Over to you, sir, please.
Dear doctors, good evening. As William Arthur Ward rightly said, feeling gratitude and not expressing it is like wrapping a present and not giving it. So, on behalf of Team Himalaya, I would like to thank Dr. Nagarajaya for his gracious presence and for being the speaker of this session. Thank you. And a special thanks and gratitude to all the doctors on board for your valuable presence and support and patronage. And sincere thanks and kudos to all the Himalayans who have joined hands together to organize this event and make it a big success. Also, I thank the prescription RX event for their attachment with us, and my deepest sense of gratitude and appreciation to all those who made this event a resounding success. Once again, thank you all. Jai Hind, Jai Himalaya.
Thank you, sir. Once again, thank you all. I think with that, we'll conclude the session.
Thank you, sir.
Yes, thank you so much.